Thank you for the invitation and for your introduction, for your kind introduction. It is, of course, a pleasure to be here and to discuss the management of refractory OEB. These are my disclosures, which might be relevant for the lecture today. And I would like to start by discussing the concept of refractory OEB today. A few years ago it was very clear where the patients that could not tolerate or did not respond to antimuscarinic drugs. But nowadays we have two classes of drugs that are available for the treatment of OEB. So we have also the beta-3 agonist mirabegron. And so should we consider that the patients are refractory when they did not respond to both drugs? And the problem is even worse if we consider that the drugs can be combined, add-on or in combination, and so eventually the concept of refractoriness should probably be extended also to combination. That is something that we should consider in the future. But for today, I'm going to consider refractory OEB as the cases of OEB that do not respond to antimuscarinic drugs. And the reason is simple. Antimuscarinic drugs are still strongly recommended by the EU guidelines, all of them, extended release formulations or immediate release formulations, they are strongly recommended. And in many health care services, authorities prefer antimuscarinics in first place because they are cheaper, because they are in most cases generics, and some countries do not have yet the beta-3 agonist. Why antimuscarinic drugs do not work in all patients, and we know that many patients, or the majority of the patients, stop antimuscarinic drugs very quickly after prescription, within the first 3 months. And the main reasons are, in fact, lack of efficacy and adverse side effects. And lack of efficacy is surprising, isn't it? It's surprising. But if we see this table that is now included in guidelines, we can see that the probability for a patient to be dry after antimuscarinic drugs is in fact very low. And the number of patients that we need to treat to get one patient dry may range from 6 to 12 patients and to get one patient dry, which is not a fantastic number. And why is this? The reason is also simple. The antimuscarinic drugs are available in low doses due to the narrow therapeutic window they have. If the yellow triangle indicates the concentration of antimuscarinic drugs, if we increase the dose, immediately we have side effects like dry mouth, and eventually in higher doses we might compromise voiding contractions and eventually lead the patients into urinary retention. So they are available in low doses. And it's not my concept, this is based on the analysis of several clinical trials in which dose escalation was possible. So on the top of each bar is the percentage of patients that asked for dose escalation because they were not satisfied by the lower dose. Now I am going to remove the comparator. So we have the numbers for solifenacin, darifenacin, and fesoterodine, and 50 to 60% of the patients were not satisfied with the low dose. Of course, in these 50 to 60% of our patients, we can increase the dose, but then we have this problem. The trade-off line of antimuscarinic drugs is very clear. If we increase the dose, we increase the probability of adverse events. And that is the biggest problem with antimuscarinic drugs and with dose escalation. In addition, we have to take in mind that recently a paper or two papers in JAMA showed that in patients under prolonged treatment with antimuscarinic drugs may develop Alzheimer's disease and dementia. And that is particularly more the susceptible subjects are elderly patients that take the medication for long periods of time, like more than, in this case, 1,000 days, so more than 3 years. And in those patients, it was possible to see some atrophy of the cortex in some areas of the brain, which is, of course, an observation that should concern us. So, in this situation, I think it is good to know that we have an alternative. And the evidence that is now available for mirabegron in the EU guidelines tells us that mirabegron is more effective than placebo, is as efficacious as antimuscarinic drugs in the treatment of urgency urinary incontinence, has very low rate of adverse events, and therefore should be recommended for the treatment of OEB and urgency urinary incontinence, with one exception, patients who have severe uncontrolled hypertension. Why do we say that, or wrote in the guidelines, that it is as efficacious as antimuscarinic drugs? This is a systematic review. And the vertical line for micturitions and for the incontinence, the number of incontinence episodes per day indicates the effect, the average effect of mirabegron 50. And then the horizontal lines and the dots indicates the effects of the antimuscarinic drugs. So looking very quickly, one would say that the mean data suggests that for micturitions, to reduce the number of micturitions per day, the antimuscarinic drugs are superior, but for the treatment of incontinence, urinary incontinence, mirabegron is better. But that is not true because the horizontal lines cross the midline, and so the confidence intervals does not allow us to say that there is really a difference between the drugs. So actually the drugs are quite equivalent with the exception of solifenacin 10 milligrams. In addition, the sub-analysis of the studies, the pivotal studies that were carried out in Europe showed clearly that in patients who had received previously antimuscarinic drugs and had no response to antimuscarinic drugs, once they received mirabegron, they had a good response, while those that received tolterodine had a response that was similar to placebo, which is not a surprise because they were not responders to antimuscarinic drugs. So patients not responding to antimuscarinic drugs clearly can respond to mirabegron. And this is also true for if we analyze by age. So here it might be a little bit complex, but we have three sets of bars. This is for the study in which 25 milligrams were investigated. This is for 50 milligrams of mirabegron, and this is for tolterodine. And so this is the overall population, and here is divided for the 25 milligrams for patients above 65 and above 75, the same above 65, above 75 for mirabegron, and one can see that the numeric differences clearly favor mirabegron over placebo. We in Europe don't have the 25 milligrams, we have 50 milligrams, and clearly is effective in both in elderly patients, whether they have 65 or above 75 years of age. While for tolterodine, the situation clearly was not exactly the same, although the studies were not exactly powered to compare tolterodine in this situation, but from the numeric observation is not very favorable. In addition, in fact, and this is very important, the adverse events were very few in the pivotal trials. Actually, they were very similar to placebo, and when we compare against tolterodine, and tolterodine did extremely well in this study. On the number of patients reporting dry mouth in the mirabegron group or reporting constipation was exactly the same as in placebo. By the way, one of the reasons why this happens is because the distribution of the beta-3 receptors essentially in the adipose tissue, also in gallbladder, in uterus, and it is important to recall that there are no beta-3 receptors located in the heart or in the blood vessels, so there is actually no risk for tachycardia or hypertension. So, using the beta-3 agonists, it is possible to, in theory, to prolong the medication because we can have more efficacy and less adverse events. And this is the information coming from UK, where there is a direct comparison against tolterodine, and in average we can prolong the treatment or maintain the patients under treatment for more than 100 days when we compare mirabegron against tolterodine. But then we have the possibility of combination, and the combination can be used in patients who do not respond to one drug alone, or if we don't want to escalate antimuscarinic drugs. And there are two studies on that. One is the BSIDE study, which is an add-on study. So the patients were started on solifenacin 5. If they maintained incontinence, they were randomized to solifenacin 10, so escalation, or to the combination of Soli-5 with mirabegron 50 milligrams. And if we look to the left side, showing the change in incontinence episodes per day, although the difference is small and I don't know if it is clinically relevant, at least is as good as solifenacin 10, the combination. Actually, it was superior from the statistical point of view. And for frequency, clearly there is an advantage in using the combination of Soli-5 with mirabegron 50, and also less risk of adverse events, clearly. The other possibility is to use fixed combinations, and fixed combinations were investigated in the Synergy trial. And it is surprising to see that the Synergy trial was not particularly positive, to say, to be nice. Actually, if we look to the two combinations tested, solifenacin 5 with mirabegron 25, solifenacin 5 with mirabegron 50, and if there is a comparison with individual drugs, we don't see any big differences, and actually some of them were not even significant from the statistical point of view. So apparently, for the entire population to use combination might not be a good strategy. We might need to find the population that really needs a fixed combination. And eventually that might be the incontinent population or more severely incontinent population, because this is a secondary analysis in the Synergy study. And in both cases, the combination provided much better rates of full continence than solifenacin 5. Of course, the rates were not particularly different when compared to mirabegron 50, and so that poses the question, of the advantage of a fixed combination. But really here in incontinence might be the area where the advantage of the fixed combination might be superior if it will come out to the market. Well, but if the patients do not respond to the drugs alone or in combination, then we have to find other options. And the guidelines recommend with a grade A 2 options. One is botulinum toxin, Botox 100 units, and the other possibility is sacral neuromodulation. For botulinum toxin, this is the pooled analysis of the 2 pivotal trials. One can see that whether the patients had received 1, 2, or 3 antimuscarinic drugs before the botulinum toxin was effective, whether also the patients did not respond to antimuscarinic drugs because of lack of efficacy or because they could not tolerate the side effects. Also, in additional sub-analysis of these pivotal trials, the effect of botulinum toxin was identical in younger and elderly patients, below 65, above 65. So age is not a problem in terms of efficacy of the drug, botulinum toxin. And prolonged administration up to 5 treatment cycles here, one can see that the average decrease in the number of incontinence episodes remains very similar. Of course, botulinum toxin has side effects, and the most important are urinary tract infections and urinary retention. And this year it was presented in a way, and I will present in SIU within 15 days the same study. So I decided to bring some data from the poster I will present in Lisbon here. It is an analysis by age. The patients were divided by decades, and one can see that the risk of urinary retention is higher in elderly patients, but is very low in younger patients. Efficacy was good throughout the entire population, so that might be relevant to inform our patients that if particularly they are young and they are afraid of urinary retention, that the risk in young patients is in fact very low. Also, in terms of urinary tract infections, the risk in younger patients is lower than the risk in elderly patients, and this has certainly should certainly be related with the increase in post-void residual, which is higher in elderly patients. Botulinum toxin was compared against antimuscarinic drugs, optimized administration of solifenacin with dose escalation, with replacement of solifenacin with trospium. And this is the ABC trial, and the initial results were surprising. The decrease in the number of incontinence episodes, the mean decrease from baseline, was exactly the same for antimuscarinic drugs and for botulinum toxin. For a population with a high number of incontinence episodes per day, around 5 per day. However, it is important to see that the percentage of patients that were fully continent after botulinum toxin was 27%, so the double of the percentage of patients that achieved full continence with solifenacin. And in fact, this is a meta-analysis that was published by Marcus Drake this year, where we can easily conclude that the probability of being dry using botulinum toxin is probably the double when compared to all antimuscarinic drugs and to mirabegron 50, with mirabegron 25 the difference is even larger. The other option, of course, is sacral neuromodulation. I must say that the way sacral neuromodulation has been compared up to now is not exactly the same way, and many studies considered a patient as full continent if the decrease in the number of incontinence episodes is around 90%. And one can see that this 90% improvement is sustained in time, although there is a gradual decrease, and at 5 years we might expect 15% of the patients fully dry, if we accept that 90% is fully dry. Of course, this has, so it is an effective treatment, although the number of complications or adverse events is relatively high, and we should inform our patients that most probably 1/3 of the patients might require some form of surgical revision of the devices due to several reasons, battery, lead repositioning, explantation, whatever. And so, finally, direct comparison between botulinum and sacral neuromodulation appeared in this Rosetta study. Unfortunately, the dose of botulinum used is 200 units, so it is not the recommended dose for the treatment of OEB. But what is important from this study is that the mean decrease in the number of incontinence episodes is better for botulinum when compared to sacral neuromodulation. And if we look into the percentage of patients that were dry at 12 weeks, clearly there is an advantage for botulinum 20% of the patients were dry, only 4% of the patients with sacral neuromodulation were dry, and a reduction of 50%, or 75%, sorry, the difference is also substantial and in favor of botulinum toxin. Of course, the complications we can expect from the two treatments are completely different, and those that we have already referred to. Finally, we have bladder augmentation if sacral neuromodulation and botulinum do not work. And I must say that for OEB, I never used, until now, bladder augmentation. This is a bladder augmentation for a small capacity, non-compliant bladder due to radiation cystitis. For OEB, we never used, and we should be very careful about using these in OEB patients because there are a lot of complications associated with this surgery, particularly long-term complications. Patients should be informed that the risk of urinary retention and necessity of emptying the nail bladder with intermittent catheterization is real. The risk of formation of stones is real. Metabolic disturbances is real. Urinary tract infections, of course, bacteriuria, symptomatic bacteriuria is highly common after bladder augmentation, and symptomatic infections might be a problem. So this kind of surgery should be eventually reserved for very, very specific patients, and it's, I should say, not a treatment for the majority of OEB patients refractory to medical treatment. So the conclusions, I think we should eventually in the future define to have a better terminology for the concept of refractory OEB, should be to antimuscarinic drugs, and beta-3 drugs in combination or alone. Remember that the two classes of drugs, because they have a different mechanism of action, can be combined, and so eventually we might reduce the dose of antimuscarinic drugs in elderly patients, which might be significant for the cognitive effects that potentially might complicate the chronic administration of antimuscarinic drugs. Onabotulinumtoxin A offers much higher probability of having a dry patient than antimuscarinic drugs or mirabegron. Is better, according to the Rosetta study, than sacral neuromodulation, and blood augmentation should only be used in selected cases. And so, thank you very much for the invitation and for your attention, and I will be glad to answer some of your questions.